You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. On today's episode of The Dish on Health IT, hosts Tony Schueth, CEO of Point of Care Partners, and Kim Boyd, POCP Regulatory Resource Center lead, sit down with Pam Schweitzer, an industry veteran, former Assistant Surgeon General of the United States, and chair of the NCPDP Foundation Board. Together, they dive into the critical topics such as health IT policy, public health modernization, and pharmacy interoperability, exploring how these initiatives impact stakeholders across the healthcare ecosystem. This engaging conversation between longtime colleagues is both insightful and fun. We hope you enjoy this episode. If you have ideas for future podcasts, email us at podcast@pocp.com or submit suggestions on our podcast page at pocp.com.
Hello, everyone, and welcome to The Dish on Health IT, where we invite health IT innovators and trend makers to discuss some of health IT's biggest news and most exciting milestones. Point of Care Partners is a health IT consultancy and trusted third party that works with stakeholders across the healthcare ecosystem, providing independent and objective insights and strategic recommendations based on our deep expertise. I'm Tony Schueth, CEO of Point of Care Partners, and I'll be your host for this episode. I'm joined today by my co-host, Kim Boyd, our Regulatory Resource Center lead and a senior consultant here at Point of Care Partners, and really one of the most well-regarded industry experts on health IT policy, interoperability, and pharmacy standards. We are both thrilled to welcome Pam Schweitzer, former Assistant Surgeon General of the United States and current chair of the NCPDP Foundation Board, and a member of the Board of Directors of the NCPA Innovation Center. Both Kim and I are honored to have known Pam for years, and we're really looking forward to this fun discussion today, where we'll discuss health IT policy, landscape, public health data modernization initiatives, interoperability, and how all these things interconnect and impact stakeholders across the ecosystem. But before we jump into our discussion, I'd like to ask Kim to briefly introduce herself and tell us what she's looking forward to learning from today's discussion. Kim?
Hi, Tony, and good morning. Good morning, Pam. Tony, I think one thing that didn't get mentioned is I'm a huge policy nerd that ties all this policy stuff to strategy. Like, what does it mean? What does everything that's coming at us in healthcare and healthcare IT mean for us? So I have the distinct pleasure of working with some really smart people here at Point of Care Partners who are focused on those strategic initiatives in order to create change in healthcare. So, and one of those passionate people, although she doesn't consult for Point of Care Partners, is most definitely Pam. She is so passionate. And Pam, I'm so glad to have you on here and just to hear about your deep involvement that you've had for decades now in improving the patient's experience in healthcare and linking together yourself and other passionate experts for many causes. So I'm definitely interested in hearing your perspectives on the linkage between all the various healthcare interoperability efforts, including some of the policies I think we'll talk about today, and how those flow down into the public health infrastructure and what does it mean for public health today and tomorrow. So thanks, Tony. I appreciate it.
Thanks for that introduction. And Pam and I also serve on the NCPDP Foundation Board together, so it's fun that we get to talk in this environment. But Pam, why don't you please take a moment to introduce yourself, including your background and what you're doing these days besides the NCPDP Foundation Board.
Thanks for having me. And Kim and I have known each other for years, back when I was at CMS, and actually when I was the Assistant Surgeon General too there. We've known each other back in those days. And then, Tony, it's great to have you on the board. I really appreciate the opportunity to talk about this topic. And you knew right when you mentioned it, I was like, yes, because I love this topic so much. So I'm going to give people kind of a perspective on where I'm coming from. I started off early in my career in the Indian Health Service. And while I was there, and I'm just going to give you the view of the world from there. And I'm thinking, I didn't realize they didn't do this in the private sector. So, and I also worked at the VA. So back in those days, I was there when everything was paper. So during that time, patients carried their charts around. They had access to their charts. They had access to all that information. For a little bit later on, I remember we put them in these bags that had to be unlocked by the providers, but still the patient's chart was the patient's chart. So both in the Indian Health Service and in the VA. And then I was there. I was actually the transformation lead when we went from, in the Indian Health Service, when we went from paper to electronic, an electronic health record. So there, I got to see how complex this whole thing is, communicating with the radiology department, with the labs, with the admissions, just all how complex that was. And it took us a little bit of time, but we got all the right people together, brainstormed, made a plan about how do you move forward with these projects, these huge IT projects, to be able to do it in the right order so that it flows right. How do you work in the workflow? How do you change the business processes? There was teams of people that we had working on this, and I was really fortunate to be able to be there to see all that through. And then, so I wanted to share that with you. That's so my perspective of how complex it is and the approach to implement, how you have to do this. And some of these same levers that they're using now, we had to have them used on us. Why are we going to even do it? I'm not going to do it. What's going to make us do it? How do we move forward? What inspires us to do this? So the other thing I wanted to share, and this impacts my background a little bit, because when I was working at for a tribe, so this is mid-career, I was working for a tribe. I remember they were very vocal about how they wanted care provided to them. And it's almost like the light bulb turned on. What? Because we're trained in school. You have diabetes. Here's the plan. Here's what you do. So it was a big shift to go around to listen and to understand, well, this is what's important to us. Diabetes, and I'm just making something up right now, but that may not be the most important issue to them. There might be something important. It might be access to clean water, or it might be access to a good food supply that impacts all of this. So the light bulb turned on to me like, wait a second, we've got to rethink about how we are providing care, or how we taking care of care in our communities. And the voice of the community, the voice of patients, we need to do a much better job of listening, because right now it's not that way. And we'll talk a little bit more about, just because these are being around this, just thoughts on this. And I'm really happy to see this discussion, because the federal government is also taking all this information in, trying to move the needle, but you've got to do it in a nice, slow, systematic method. Too fast doesn't work. So I'm really, really happy that both these, the topic that we're talking about. So anyway, hopefully it gives you a background of where I come from. And as far as what I'm working on now, so I've been retired, and I decided to just work on things that are exciting to me. And so I'm so excited, because the things I'm working on, I am passionate about. Maternal health is one area, our food supply, nutrition, food supply, working on those areas. And then, of course, all the immunizations, vaccinations, things for pharmacy. I'm going to always be around. Anything for pharmacy, of course, I'm there. But these other areas, the nutrition, food supply, maternal health, those are other spaces right now that I'm very interested in. And it's mainly because, as we both have grandkids, trying to help this next generation be as healthy as they can, as they get older. So,
for the record, that's Kim and Pam that have grandkids, not Tony.
Okay, all right. So for Kim and Pam having grandkids, yeah.
And love them to death.
And Pam, I also remember the early days of hospitals and putting, all our correspondence in mailboxes that the doctor would have to go and get. So I remember the paper days as well. But we've evolved from that. And
yes.
How do you see healthcare IT policies like improving prior authorization and progressing interoperability rule, or CMS 0057 for short, and the HTI-2 proposed rule shaping the future of interoperability, including interoperability of public health?
Well, when they put these all together, I'm so happy they did. This is a result of them listening to stakeholders. So people coming out and wanting to move forward. And for us to even move forward, there has to be infrastructure in place. So they want to, okay, what's the infrastructure that needs to be put in place? What do we need in place to be able to fix some of these things? So we have to have standards for data sharing. We can go on for that. We need to have, we want innovation. How are we going to inspire innovation in some different approaches, different workforce models? The one thing we've all learned is one size doesn't fit all. We've got to be able to allow for different models depending on the strengths of the communities, the strengths of whoever's providing that service too. And then data stewardship and governance. So all this infrastructure really needs to be in place as we move forward. And we're coming across this as people are trying to do something and then they get stuck. So then they get that information and they pass that on. So a lot of these are the federal government, CMS. I'm saying really HHS because this is HHS wide, because I didn't realize this. I should probably get a little sidetracked here. When I was working in the government, I didn't realize they all talk to each other. They talk to each other quite well. And so anyway, coordinating between all of them, making sure they all understand it too is important. And when I say that, we have HRSA that's involved. That's a provider workforce, our healthcare workforce. That's a really important area too. Drug approvals. So I think all of these things are a result of listening to stakeholders and coming together, talking to the different people and figure out how do we move this forward. And they're taking that information and moving it forward. And I know NCPDP, they provide a lot of background data information to help that, but it's also the other payers, the providers, everybody's providing input for them to put these together. And Kim, you probably have more to say on this.
Yeah, Kim, our health policy nerd. I'm sure you want to chime in now.
Pam, I think you made a great point, right? You were talking about the collaboration across the agencies. I will say that probably over the course of the last 5 years or so, I've seen greater continuity and coordination between the Health and Human Services agencies, right? And now you've got ONC, who's just now been named the Assistant Secretary for Tech and Policy to better coordinate, I think, across that entire ecosystem. And it plays through in all the rules. When CMS, the final rule, CMS 0057 came out, it was clear within the text of the body and the responses from CMS that they had been collaborating with ONC, on this. It wasn't just in a silo, I'm going to kind of do this for Medicare, Medicaid. I'm going to look and coordinate across the agencies. And, that rule is impacting, you mentioned it, stakeholders, right? That rule is impacting Medicare, Medicaid, CHIP, federal health community to implement standardized APIs, right? And not only for the prior authorization process, right? That rule's got PA named in it, but more broadly, more payer-to-payer exchange, more provider access exchange, more patient access exchange, and availability of my information as a patient, right? This all will help with creating a more stable ecosystem and information for greater informed decision-making, as an example. And I think it's substantial. I think the impact on interoperability from this rule and the HTI-2 rule as well, it's proposed. So let's level set with that. HTI-2 is proposed right now, not final. But these policies are driving the need for real-time data exchange between providers, between payers, between patients, and those entities in the middle that help them, including this flow through to public health, which we're talking a little bit about today. And that the HTI-2 proposed rule is also focusing on advancing interoperability holistically and improving that information sharing that we were talking about, including the flow through to public health. Right. It introduces new voluntary certification criteria for health IT systems, emphasizing standards like you were just talking about, NCPDP, and then there's HL7 and the FHIR standards. So it's introducing these new models of certification and technology and APIs to enhance that end-to-end data exchange, which is amazing. I think we're seeing this transformation over the last 5 years or so like we hadn't seen in previous years. It's, to your point, it's been a little bit of a slow walk, but we're getting a little bit faster. And you mentioned medications and drug therapies, right? So the HTI-2 rule is also has mentioned and referenced the CDC's Data Modernization Initiative, which also aims to improve public health response capabilities. So I think, by fostering this more connected and efficient healthcare and healthcare IT ecosystem, the HTI-2 rule, if passed as written, I think will enable public health authorities with greater access and to utilize the data more effectively, including maternal health. So Pam, the HTI-2 rule has a maternal health perspective in it. So I think these policies are just, additional levers to create innovation and move information more readily for informed decision making and preparedness for the next pandemic, which we will have.
Thanks, Kim. That's really insightful. You mentioned, public health. So Pam, what are some critical steps in modernizing public health data systems, and how can stakeholders like payers, health tech vendors, and providers contribute to this effort?
I love that question. So this is back a while now. This is several years ago. I remember, and I'm a pharmacist, by the way. I should probably tell you I'm a pharmacist. One of the things that we learned in school, and it stuck with me to this day, is that tobacco use causes regular tobacco use causes an increase in the enzymes, the P450 enzymes. So they metabolize drugs quicker. You metabolize drugs quicker. So I always thought, and I always worked with, we always knew that status for people when I was working in this closed system, because especially if they're going to stop smoking or they're going to stop using tobacco, it's going to impact the other drugs that they're on differently. Well, I found out that there's not a place to put that in the pharmacy systems, or if it is, it's all over the place. And wouldn't that be nice? Just one data element to be able to transfer that from a hospital or send that somewhere. And I'm not talking we bigger than just that one piece. That is so difficult. And it's really, we can't do it. And so anyway, that's when I realized, okay, we got to think of something simple, because part of it was, what can we work on to start moving back and forth? So that's public health, tobacco use. When COVID came, when there was COVID, we were used to being able to have data when you have a pandemic, or just when you have any type of public health crisis, whatever it is, a hurricane, something, you need to be able to have data. And one of the things on the public health, I found out they don't talk. They're not talking to the healthcare system. There's no communication between them. But down, boots on the ground, and I'm talking pharmacies now, there's a lot of people, boots on the ground, they kind of know what's going on, but there's no data that gets up. Because if I'm the public health in a community or a state, I want to put resources where I need them. I don't even have data to do that. And so we've got to do a much better job of collecting that data. And I remember reaching out, and people might have their data, but they don't share it. This is not something that we can keep a secret. This is something we need to put resources where we need to put them, and we need to do it. We need to know the ethnic backgrounds. We need to know the transportation needs. We need to know all these other elements that impact the community, and we don't have them. And the public health department needs them too. We all need them. So part of this, and we knew this all along, that we need to do a better job of collecting and having and providing and sharing this information. And then the other piece is being able to respond is also, we need to know who the payer is too, because a lot of times we'll have disparities within a community depending on the breakdown of what the payer type is too. So there's certain data elements that are really needed, and the community can help decide some of these, but we at least to be able to need to do it and share it, because otherwise we're going to do what we do now is everybody collects a separate information if they need it. And it's just, we shouldn't need to do this. We should be able to share this information back and forth.
Absolutely. And when you talk about sharing, one of the major developments over the last year is TEFCA going operational. There's only a handful of QHINs now, but looking forward, how do you see pharmacy and public health factoring in with TEFCA, Pam?
Well, I'm going to have Kim help with this one here, because I knew this came out, in 2016 or something, it came down, and it's basically people getting together and realizing, it affected information blocking. Mm-hmm. It impacted, what are all the issues that are keeping us right now? We need some governance over here. What's keeping us from data sharing? And it's really working on, and that kind of laid the groundwork for this, where we're going right now. And moving forward on this. And I remember weekly meetings. There were quite a few meetings on this, getting input. They were very open to all the stakeholders contributing and getting information. It was a really great start to all this. And I think now, as we continue going through, having a forum to be able to share where we're stuck, what's keeping us from doing that, we need to always have that, be able to collect that, because a lot of times it's a policy that's keeping a policy or a rule that someone's interpreting incorrectly that needs to be clarified. So Kim, you probably can address this too. This is your area.
Back to the policy nerddom, right? So, and Pam, you mentioned it, right? We've got different sides of the ecosystem that are doing things non-common or non-standardized, and we don't have a national framework where at least everybody's kind of operating from the same sheet of music, if you would, right? Some of the challenges have been, contracts as an example, or the technical specifications on how I'm going to share with you, or how you're going to access this information, and what is the use cases for that, right? In doing that. So I think the TEFCA framework, or Trusted Exchange Framework and Common Agreement, right, is I'm going to develop a common agreement that everybody works from, same sheet of music. And we're going to have a technical framework that everybody understands the rules of the road, and build it to a national level, and instead of these regional or state, and not that it's been horrible, because some of the state framework has worked, but there is this need for a framework to develop and grow. And that's where I call them ASTPONC. That's my term for them, ASTP/ONC. Most everybody still says ONC, but I call them ASTPONC, and they're focused on that. And again, the 21st Century Cures Act was part of that catalyst, but that act came about because of the gathering of intelligence from stakeholders on what the problems were. So there is this need for an extensive, structured framework enabling individuals like ourselves to access our health information, and then create a data fluid model across these QHINS participants, sub-participants, and these are some of the same organizations that have been in healthcare for decades. And they've done things, based on their own business model, as an example. But they've been siloed, and we do have a siloed system, and it's just not working. So I think, TEFCA is this opportunity to get this connected care really off the ground and working, and incorporating those stakeholders. There's the recognized coordinated entity, Sequoia, who's helping, gather all of these perspectives, put the SOPs together, put the guidance details together, run through the application process, with ONC/ASTPONC sitting right beside them, right? And working out and establishing these rules of the road. But I am excited, and you mentioned you're a pharmacist, right? We're all in the pharmacy services world, have been for a long time. Now they're starting to engage that stakeholder a little bit more deeply into the conversation, and taking into consideration, how does a pharmacist create care for a patient beyond just dispensing of a medication, which is critically important. It's a safety-related issue, and it is a care issue, but pharmacists also have clinical autonomy as well, and being a part of that care team. But the pharmacies don't have an EHR, but the provider systems have an EHR. So how do we create these mechanisms in which to get information flowing between these care providers, including the pharmacists? So the Sequoia is standing up a pharmacy working group starting in December, and we're excited to be a part of that, both from an individual and corporate perspective, as well as partnering, with others in the industry to really figure out what are those unique use cases for TEFCA, for the pharmacy and pharmacists, and raise awareness to the pharmacies on what the opportunities might be.
I was going to just chime in and say too, for, regarding public health, and especially in rural areas, and some of the states where there's several areas, mainly because of COVID, where pharmacists are now working a lot closer with public health. And that relationship has continued, which is really important, because in those areas, they may be, especially where there's provider deserts, they may be the only provider in a part of the state.
Right. And referring out to community resources. You mentioned this earlier in some of the focus that you have. We have, we've been working on, Point of Care Partners has been working on a pharmacy interoperability white paper. And we look to release, and that was funded by the NCPDP Foundation. So, we're looking to release that in October. And, through some of that stakeholder engagement, pharmacists, not even always in the rural areas, but they're referring to community healthcare providers for other types of care that support the patient holistically, and capturing the fact that they're doing that there might be a food insecurity, that they might not have reliable transportation, right? So pandemic public health, how do I get to that patient if I need to inoculate them again for, another unfortunate public health, emergency? So those are really critical factors.
Mm-hmm. Kim, it's funny you call them ASTPONC, but we have these federal policies. ASTPONC, is one of them that provides those. There are others. We have public health data and modernization issues. We have TEFCA. Now let's dig into what it means to different stakeholders. And let's start with payers. So Pam, how do you see health IT policies impacting payers, particularly when it comes to closing care gaps and improving population health? And if you can, elaborate on how experimenting with different reimbursement models could impact the success of public health initiatives.
Oh, I love that question. There's a lot of that going on right now, experimenting with different payment models. And there's papers on this. In fact, I read those and kind of tracking them because this is how we'll drive change. But part of it is, if we go into a community, there's a mix. There could be folks that have an employer might be the biggest payer in that community. And if you look at, depending on where you are, it could be a lot of employers, or it could be the Medicaid, or it could be Medicare. There's like always a different payer mix. And then there could be a large uninsured group. So, but part of it is, and when you're looking at a population, it doesn't work right when only the haves or some people that with it is covered. So you look right now, the COVID vaccine, some of the payers are paying for it. Some of it, the patients are going to have to pay out of pocket. It's not across the board. And of course, there's not any coverage for people without insurance in general. Some of the communities are fixing that, but it's across the board. It's different. There's disparities among all of that. So really for population health, there needs to be, ideally, it would be great to have a system where some of the things, it's regardless of what your payer type. So this is all the payers coming together and working together and figuring out that model. Now, there's pockets of it around that people are trying. So if I was a payer, what I would be doing is taking a look, and maybe we can try it on a small area where we're not taking a big risk, but just dabbling in it a little bit, trying it a little bit, get everybody to chip in. With immunizations, some of the states do that. They all chip in and then everybody can get it. You see that with immunizations, and a few of the states do that. But being able to do that to take care of the population, it's obviously up to the state to decide what's important enough for us to all work, and we want to solve this problem together, whatever it is. It could be whatever public health issue is important to them. But at least they're trying and learning to work together. And then they're going to have a way to metric. So the providers are going to have to be happy. How are we going to get paid then? You're going to have the health plans. What is in it for us in the end? Because we don't want to take a big loss on this. So if you get everybody together and you look at these models, I appreciate seeing these different models and starting to get people in the state to work together to learn this. So really what we need is conveners. Somebody needs to convene all of this. Anyway, if that provides a way. Now, there's certain groups that are already kind of covered. If you're a veteran, in the federal system, they're already covered. Public health systems cover it too. It's really just convening and figuring out where the holes are and working together. And every community is going to be different. We've lived different places, as you know, Kim, and every place is going to be different. It would have a different approach. And that's why I get that so strongly, that it really just takes a convener to bring it together to say, this is important to us to move forward. And usually incentives help everybody get together. A grant or something like that will help that.
And health tech vendors are important too, aren't they, Kim? So what do health tech vendors play? What role do they play in enhancing data fluidity and interoperability? We work with health tech vendors a lot, Kim. Maybe you have a perspective on that.
Well, I think it goes back to, and Pam, what you were talking about, right? To get to what do we need as a reimbursement model, we have to have conveners, but those conveners are generally part of the health IT vendor perspective as well, right? But we have to have the data. There's got to be data that is in real time flowing through a standardized process, not siloed, to get to an infrastructure where you can create while there may be variability in the state or, relative to what they might cover, what a health plan would or would not cover for something, you still have to have the information in real time versus sending it over in an Excel file or not getting it at all or getting it 3 weeks later. There's got to be, and I think that, again, that's where some of these innovative efforts are happening, to your point, Pam, earlier about, some pilots and things of that nature. Plus, these policies are helping to drive that. None of us can make a decision, including health plans, without having the information in hand to aggregate, to come up with solutions, to be creative and innovative. And the health tech vendors help move that information, back and forth between the ecosystem. And I think that's another reason why we've seen some strong interest from tech in TAFCA as well.
Right. Tech needs to be they all need to be there at the table together, because it's really important for tech to understand on the user side, at least some folks to understand what they're trying to get at. It needs to be both ways, because otherwise we have all the tech doing their own thing, and which is what we see. And that's why, we'll put this data here. Then we can't communicate with each other. So they all sort of need to be together as they start, at least design the big picture designing, and then that constant feedback too.
Pam, I would say also at least getting us to using standards and using standardized data, right?
Yes.
And
yes.
how that data is captured, accessed, used, and exchanged.
Yes. Yes.
Right.
Yes.
You can still be creative and strategic in how you solve for problems in healthcare and still use a standard.
And you talk about having different players at the table. What about providers? Pam, as a pharmacist, you're a provider. How are health systems adapting to these policy changes? And how do all of them work together for whole person care?
I'll talk a smidge about whole person care, but I'll say on the provider standpoint, one of the pieces, and this is just from this rollout, the business, getting it in their workflow so they see the information. It's great when you collect it, but if they're not seeing it, so it's getting their input. And you might have to try it. You don't need to go fast on these early parts, because you need to figure out, how do I use this? How did this help me make a decision on something? How did it help me make a decision? And I'll just give you an example, just even lab work, going back and forth, the pharmacy not being able to get access to the lab to help with Paxlovid, to take care of that. It's like, oh my gosh, now we've got to go figure out how to do that. Well, someone's done the lab somewhere else, but that information didn't come across. So regarding whole person health, the whole concept of that, taking into account the patients, their background, where they're coming from, and making sure that we're focused on doing what matters to them. And a lot of people want this information and they want the data. They're struggling with it. And it's really confusing for the healthcare system for them. So this is part of one of the reasons why you want patients to be able to have access, or you want to be able to, how do I get into these? I need different services. How do I plug into them, these different services? How do I go find a job? I'm looking for a job. I need someone to help me with my resume. I'm just making things up right now, but it's mattering what matters to the patient. And it's for us, the providers, the pharmacists, being able to take and capture what the goals of the patient are, what's important, and to kind of incorporate that in as we're caring for the patient. So how do we capture the goals? Now, that's all it's all been built into the standards, but how do we incentivize people to collect that? And if somebody's collected it, how do we share that so we don't have to keep on asking them the same questions over and over again? Because it's really about the goals, what's important to the patient, what their values are. And so we can have that. So you're not always filling out these surveys all the time doing that. And so you can connect to the patient better too, because you know what's important. Your grandchildren are important to you. Being able to travel, being able to garden, those are activities I want to be able to do. And you can kind of connect connect to the person. I don't want to get vaccines. I don't trust anybody. So that building that in and then working with them to improve that trust over time so that they may want a vaccine. So that's what whole person health is. And it's built into the UDIS CDI. It's built in there. It's just it's going to be in the 4.0. I think it's in 4.0.
Yeah, USCDI. Version 4, which is in HTI too, by the way. Right.
And it would just be so great if folks could dapple with that one, because I know you can't boil the ocean. It's too much, but that's a really important one to patients. So if we can, not all patients, but some patients, it'd be important to be able to build that in and have IT systems, IT vendors, dapple with that and say, let's work here. Here's an opportunity to work on this between us.
Kim, we've covered a lot of ground, but I'd like you to weigh in on the impacts of these policies and initiatives on various stakeholders. You talked about payers, but we've talked about a number of others.
Well, the policies are definitely creating, this ripple effect right across our healthcare ecosystem. Payers is not an easy lift. It's not creating all of these APIs and fire exchanges, not an easy lift. They're having to revamp their systems to meet the new interoperability requirements. The health tech vendors, which we talked about, they're kind of scrambling or trying to strategically decide what to develop, what solutions need to be developed, or new connection pathways. Do they need not get involved in TEFCA kind of thing? And providers, including pharmacists like Pam, right, are looking at potentially having to adapt their workflows a little bit and take advantage of new data that might be available to them as clinicians. So it's definitely a challenging transition time, but I think one that, promises improvement in patients and patient care and coordinating on care for patients and their experience in the long run.
That's very insightful. Thanks, Kim. Pam, what are your thoughts on the role of pharmacy and pharmacy interoperability?
I think pharmacists are in such a key role, and I'm thinking of because they're so accessible to the public. You can walk in and talk with a pharmacist anytime. You can visit with them. Hey, can I talk to the pharmacist? I have a question. You can, they're so accessible in our communities. They're everywhere. And so for public health, they know what's going on. If you were to go ask a pharmacist, hey, what's going on your community? They can tell you about the opioid epidemic. They can talk about maternal health. They can talk because they have boots on the ground information, but the information is right there with them. And there is just so much opportunity. And I'm really happy that HHS sees the value of that. And that's why you're starting to see us get mentioned more in there, because the boots on the ground, they know what's going on. They actually do. You go visit with any of them. Oh, yeah, we're working here. We're doing the vaccinations here. It's just all in a silo, and nobody else knows this other information that is going on. So the other public health areas, climate change, with the different storms and floods and things like that, they know what's going on in that community. So I just think they play a huge role in public health. So that's my opinion.
Kim, I know you have a perspective on this as well. What can you share that, please?
Yeah, we mentioned a little bit of this earlier, right? We are evolving. The pharmacy practice is evolving, and it is evolving rapidly, but there is a lot of variability. As Pam mentioned earlier, you've got different state rules, you've got the feds, you've got things that are coming out of, ASCIPONC, CDC, CMS that are helping to support that. And we mentioned the Sequoia project that's being stood up. And I think that's why, is because we do have this experienced clinical team that is focused on, patient targeting and care management, improving medication management, reducing adverse events, supporting value-based care models, which we've not even talked about. We won't go there today. And then, of course, public health. So getting to a core incentivized way for pharmacists to integrate in their systems, to not be as siloed and integrate with the rest of the ecosystem, I think is going to be our next challenges.
Pam, what's your view on our next challenges? How do we get to the future of public health modernization and interoperability? What's it going to take for us to get there?
Well, this is the part that I love a lot. This is like implementation type thing. Part of it is to have key people sort of understand and willing to help get the first steps going. And that's why I'll be honest with you, the foundation is awesome because it helps fund these, let's do this idea and see if we can make something out of it and learn lessons learned that we can share. So anyway, taking some of those first steps and trying to implement and make impact in the community. Once it gets going, it's great. But these first steps of getting these, I call them influencers, I call them champions, whoever they are, to take those first steps to try to and work out the bugs and work with the vendors and work with the payers and work with everybody to kind of work out the problems. That's how you move something forward. So I think that's what's kind of needed, and people to understand this education. And then the term I use is plant seeds. Start planting seeds across the board about the direction here we're going. And they may not be ready now, but at least they're thinking about it, and they're going to start paying attention to it a little bit more because this is a direction we're going to move. And listen to the reasons why people don't want to move forward and kind of gather those. And let's start talking about that a little bit more. So I'm all for hearing where the blocks are. Blocks to me are where there's going to be a challenge, and maybe we're not ready for that piece, but there's other pieces that we are ready. Let's start moving forward on those. Is that too vague? Is that too vague what I just said?
Not at all. I'm with you on planting seeds. I'm obviously with you on the board.
Yes.
and the importance of, they're doing, the foundation board, and yes. The foundation is doing some wonderful things, funding all kinds of great projects.
Right.
As we're really to the point where we're kind of winding down this podcast. And what I'd like to do is sort of shift to kind of final thoughts. And Pam just gave the last answer. Maybe we can start with you. Kind of, what's your final thoughts on pharmacy and interoperability and regulations and how we sort of evolve and provide better care to our patients?
Yeah, great question, Tony. And Pam, thank you again for joining us today. It's always such a pleasure, hearing your brain trust and figuring out, how we can continue to partner together to create change in healthcare. I think, as I mentioned before, right, we've had this catalyst over the course of probably the last 5 years where all kinds of regulations are coming out, again, predominantly from 21st Century Cares Act. To move the needle on, interoperability. And that's a big word, right? But when, meaningful use came out and things of that nature, pharmacists wasn't included in that, but pharmacists are included in, the information blocking in 21st Century Cares, but we've seen this expansion, this growth and expansion of opportunity in the pharmacy and for pharmacists to partner more closely with the other parts of the care team. And, NCPDP has been working very diligently probably in the last 2.5 years to create an ecosystem for innovation. And how do we prove out these use cases? And I agree. I think you have to have some defined use cases to work towards. And Da Vinci did that, the Da Vinci Accelerator, right? That's how they started with their use cases. They started with a couple of use cases and built on that and got the feedback that Pam was talking about. So, overall, I'm excited for what is ahead for us and looking forward to continue to collaborate with Pam and others in the industry to take these steps, these actionable steps to create change for patients.
Pam, do you have any final thoughts?
I was just going to say, I am so pleased with just the momentum that I see going now. For a little while, it stalled. But I think that was just post-COVID burnout. And now I see just a lot of movement, and it's very exciting, very hopeful. So I'm really pleased. I was going to say I had the opportunity to witness, there was a PASIO project, and they had where I got to see the demo of the information going to post-acute care. It was a discharge from a hospital, the information, drug profile, go back and forth. And it worked. And so that's huge to be able to see that going back and forth from a community pharmacy, pharmacy to a hospital to a pharmacy. And so there's a lot of momentum going. So anyway, the tech people are so smart. The technology folks, once they have good direction, that's why the input of both is so important. there isn't anything they can't do. I have been around them. They are geniuses, and I'm just in awe of them. And I think it's really up to the users, the providers, the payers, everybody to help guide the direction, because tech can make anything happen. That's my opinion. I've seen it over and over and over again. Once they visualize, everybody can visualize it, they can make it happen.
Music to our ears. Tech can make it happen. Pam, in closing, I'd like to thank my POCP co-host and policy expert, or policy nerd, Kim Boyd. I remember, I'm just going to jump in and say, I remember when nerd was like a bad thing, and then it became really cool, and now it's really cool to call yourself a nerd. So Kim is our policy nerd. And our esteemed guest, Pam Schweitzer. It's been a pleasure catching up with both of you today. Just a friendly reminder to new listeners that you can find us on Apple Podcasts, Spotify, or whatever platform you use to pick your podcasts, including Healthcare Now Radio. We also post videos of our podcast episodes, sometimes longer versions, on the POCP YouTube channel. And don't forget, Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with fire accelerators? Email us at interoperoutlook@pocp.com to learn more about our new Interoperability Outlook subscription monitoring service.